Assalamu alaikum viewers. I am Professor Pulsus and today I will be talking about the first part of the cardiovascular system examination, and that is the pulse.
There is one basic principle to palpate the artery, and that is always palpate the artery over the bone. Then there are few arteries which are palpated with the thumb, and these include the brachial artery, the carotid artery, and the femoral artery. Where to palpate the different arteries? First of all, for the radial artery, the arm should be slightly pronated, the wrist slightly flexed. Place your 3 fingers over the radial artery and palpate it. It is more easily accessible compared to the ulnar artery. Then, for the brachial artery, you place your thumb just above the cubital fossa like this and palpate the brachial artery. For axillary artery, you need to press against the humerus to feel the axillary artery. For carotid artery, place your thumb just below the angle of the mandible and palpate it. Abdominal aorta ends 1 inch below and to the left of the umbilicus. So above it and slightly to the left, you can palpate the abdominal aorta in the thin lean people. Below that, we go to the femoral artery, and for the femoral palpation of the femoral artery, and to avoid the embarrassment if you are a female and the patient is of the opposite sex or vice versa. To palpate the femoral artery, place your hand over the greater trochanter, bring your thumb below the inguinal ligament and press it and feel the femoral artery. This is to avoid the embarrassment of all the patients and particularly of the opposite sex. How to palpate the dorsalis pedis artery? Place your 3 fingers in the first web space and bring it proximally over the bone till you feel the arteries. Because this dorsalis pedis artery, it dips into the first web space at its start and then goes to the plantar side. So it will not be palpable over here. It's only palpable when you bring your fingers proximally. Then comes the posterior tibial artery. Feel the posterior tibial artery between the medial malleolus and the heel, midway between the two. The artery travels like this. So place your 3 fingers over here and feel the posterior tibial artery. You slightly flex the knee, bring your fingers in the center, press them into the popliteal fossa and thumbs over the front of the knee joint and feel the popliteal artery. So this is how you feel the different arteries. To take the radial pulse, place your 3 fingers over the radial artery with the arm and slightly pronated and wrist slightly flexed, and use your watch to take the rate of the pulse. Count it in 1 minute or maybe 30 seconds and multiply it by the 2. So this is the rate. Whenever you take the rate, the abnormality associated with the rate is the sinus arrhythmia. In sinus arrhythmia, the pulse rate increases at the end of the inspiration and it slows down in the expiration. You concentrate on the respiratory cycle and see if there is any change in the inspiration or expiration. To confirm it, take the long lead 2 of the patient in inspiration and expiration, and you will be able to clearly demonstrate the difference between the inspiration and expiration. After the rate, we note down the rhythm. Now what is the rhythm? The rhythm can be regular, or the regular rhythm is also called the sinus rhythm. This means when you take the pulse, the beat to beat interval is constant. If this is constant, we will say that the patient has got the sinus rhythm. It can be regularly irregular, which means there might be a premature beat or extrasystole after every 2, 3, 4 or 5 beats. If such is the case, you will say that it is regularly irregular. Now, again, the next abnormality can be irregularly irregular. The irregularly irregular pulse is that which is irregular in time as well as in volume. Both its rate and the volume will be constantly varying from beat to beat. And whenever you find this, take the heart rate of the patient. And you will find that the heart rate of the patient is higher compared to the pulse rate. And this difference between the heart rate and the pulse rate is called the pulse deficit, because some of the heartbeats, they are not strong enough to generate the pulse in the peripheral arteries. Another abnormality of the pulse is, which is related to the volume, that in some of the patient you can find the one pulse beat is strong and the second is of relatively low volume. Then you will say that the patient has got the pulsus arterial. The volume of the pulse is the force with which you feel the pulse. And what will be for a normal person? That will be called the average normal volume pulse, which you come across in majority of your patients. If the pulse is of low volume, again you think of the conditions which can produce the low volume pulse. Then the high volume pulse, in which you feel a strong and forceful pulse over the peripheral arteries, maybe over the radial artery. Whenever you find the high volume pulse, you need to check for the collapsing pulse. And to check for the collapsing pulse, you place the distal part of your palm over the radial artery like this, hold the wrist, tighten the grip till you are able to feel the pulse of the radial artery over the distal part of your palm. Then elevate the limb and make it vertical and concentrate on the pulse volume. If it increases when you make the arm vertical, then you will say that the patient has got collapsing pulse, but reconfirm it by bringing it down. When you bring it down, the pulse volume again will come to the normal. So this increase in the pulse volume is called the collapsing pulse. Now if you find the collapsing pulse, the next thing is you take the blood pressure of the patient and note down the pulse pressure, which is the systolic minus the diastolic pressure. If the pulse pressure is equal to the diastolic pressure or more than that, you will say that the patient has got a wide pulse pressure. So definition of the wide pulse pressure is the pressure which is either equal to or more than the diastolic pressure. And if the pulse pressure is wide, this will be a real collapsing pulse. But there might be patients in which you find the collapsing pulse clinically, but the pulse pressure is not wide, meaning thereby it is not equal to the diastolic, it is rather lower than the diastolic pressure. If such is the situation, this will be called minimal collapse, which you commonly come across in patients with the high fever, arteriovenous fistulas, hyperdynamic circulation, and all these conditions in which there is hyperdynamic circulation, maybe anemia, you can find the collapsing pulse, but the pulse pressure will not be wide, so hence it will be called the minimal collapse. After noting down this character, then the next character is Pulsus paradoxus. How you pick up the Pulsus paradoxus? When you take the pulse, concentrate on the respiratory cycle of the patient and the volume of the pulse at the same time. If the pulse volume becomes decreased at the end of the inspiration, or it disappears, you feel like as if the pulse has disappeared, then you suspect the pulsus paradoxus. And how to demonstrate the pulsus paradoxus is that you apply the BP apparatus cuff over the arm, inflate it above the systolic, and then slowly deflate the column, which is about 1 to 2 millimeters per second at a rate of 1 to 2 millimeters per second. Note down the reading of the first crop of sound which you hear. This will be in the expiration. So first sound you will hear on deflation is during the expiration. Slowly, gradually deflate it till you come to a point where the crotch cuff sounds are doubled. This is because now the crotch cuff sounds will be audible in the inspiration as well as expiration. So the difference between the two, where you listen first crotch cuff sound and where you listen during the inspiration as well as expiration. And if this is more than 10 millimeter of mercury, this will be called the pulsus paradoxus. There are few other characters as well, which includes the anacrotic pulse, in which there is a slow rise of the pulse with a one peak over it. You may be able to pick it up in patients with the aortic stenosis. Then there can be a dicrotic pulse, in which there is a double peak in each pulse, and this is seen in patients with the aortic valve. So these are the different characters related to the volume of the pulse. Then comes the tension. The tension of the vessel wall depends upon the diastolic pressure. And if the artery appears soft during the pulses, then it is normal. And if it appears slightly firm, then it is the pulsus tuberus. Then the palpation of the vessel wall. The vessel wall, to palpate the vessel wall, the artery needs to be blocked from both the distal as well as proximal ends, because in the hand we have the two arches, superficial and deep palmar arches, which communicate the ulnar artery with the radial artery. So to feel the vessel wall, you place your three fingers over the radial artery, you press the proximal one and you press the distal one as well, so forcefully that you are unable to feel the pulse with your middle finger, and when no pulse is palpable, then move your finger like this and feel the artery. If the vessel wall is thick, the artery will appear cord-like, but if it is normal, then the vessel wall or the vessel will not be palpable when you block it from the both proximal as well as the distal ends. So this was for the palpation of the vessel wall. And then we come to the comparison of the pulses. And in the comparison of the pulses, the two are important. One is the radio-radial and then is the radio-femoral delay. For radio-radial delay, you feel the radial artery with your one hand and you place the fingers on the other radial artery and concentrate on the palpation on both sides, whether both the pulses they are felt at the same time. If they are felt at the same time, then you will say that there is no radio-radial delay. For radio-femoral delay, you place your one hand over the radial artery and other over the femoral artery and feel both the pulses. If they are palpable at the same time, then there is no radio-femoral delay. The radio-radial delay you can find in patients with the preductal coarctation of the aorta, and the radio-femoral delay in patients with the coarctation of the aorta of the thoracic and of the lumbar region. Sometimes you listen bruit over different arteries. These can be audible in the carotid artery. You place the strap over the neck below the angle of the mandible, and you ask the patient to hold the breath so that the breath sounds they are not transmitted, and you listen to the bruit. This bruit over the neck can be due to the carotid artery, it can be due to the thyroid, it can be due to the transmitted murmur, or it can be a venous hum. Now, how do you differentiate all these? The transmitted murmur will be audible over the base of the heart, while the thyroid bruit will be audible more close to the thyroid compared to the base of the heart or over the side of the neck. Now, there we are left with the carotid bruit and venous hum. Now, to differentiate between the arterial bruit and the venous hum, you apply pressure over the base of the neck and the venous hum will disappear because it will block the internal jugular vein. So, this blockage of the internal jugular vein will lead to the disappearance of the venous hum, while the arterial bruit that will persist. Similarly, you can listen the bruit over the abdominal aorta, and at times you have to differentiate it from the bruit of a mass in the liver or maybe a hepatocellular carcinoma. And to differentiate the two, you have to bring the patient into the knee elbow position and then you auscultate from below and listen to the bruit. If the bruit in this position remains the same as it was in the supine position, then this is because of the mass in the liver or the hepatocellular carcinoma, or it is a hepatic bruit. While if it becomes less in intensity, then this will be the aortic.
Thank you very much for your attention, and Allah Hafiz.